INASL 2025. We begin with the first session on presidential oration. May I please take the honor to invite Dr. Brajesh C. Sharma. Sir is the President-elect INASL, also the Professor and Head, Department of Gastroenterology, GB Pant Hospital. May I also take the honor to invite Dr. Ajay Duseja. Sir is the Secretary General INASL and also the organizing chairperson for INASL 2025.
Good morning, everyone. So I welcome you all to this prestigious presidential oration for the year 2025. And the president of INASL is Professor Radha K. Dhiman. So Professor Dhiman presently is the director of Sanjay Gandhi Postgraduate Institute of Medical Sciences, Lucknow. Before that, he was heading the Department of Hepatology at PGI Chandigarh. Professor Dhiman was born on 4th of June 1960, and he received his initial training in MBBS and MD from King George Medical College, Lucknow in 84 and 87 respectively. And then he did his DM gastroenterology from SGPGI Lucknow in 1991. He's a bestowed fellow from several institutions, including American College of Gastroenterology, American Association for Study of Liver Diseases, Royal College of Physicians, London and Edinburgh, and National Academy of Medical Sciences. Dr. Dhiman, we know, was instrumental in devising a cost-effective algorithm for the treatment of hepatitis C at the public health level under the Mukhyamantri Punjab Hepatitis C Relief Fund. We discussed this yesterday during the inauguration also. The program was further expanded for microelimination for HCV infection in other populations like co-infection with HIV, incarcerated persons, persons who inject drugs, and persons on oral substitution therapy. Based on the success of Punjab model, Government of India launched the National Viral Hepatitis Control Program on 28th of July 2018 with provision of free diagnosis and treatment for viral hepatitis through the National Health Mission. Dr. Dhiman is recipient of numerous national and international awards and honors. He was awarded Padma Shri in 2024 by the President of India, Srimati Draupadi Murmu, and Dr. B.C. Roy, National Award, highest in the medical field, by the President of India, Srimati Pratibha Patil in 2008. He's recipient of 4 times ICMR awards. He has the honor of being the president of prestigious International Society on Hepatic Encephalopathy and Nitrogen Metabolism for 6 consecutive years from 2012 to 2019, and this we know is all because of his phenomenal work which he has done in the area of acute liver failure and hepatic encephalopathy. He was also the Secretary General for Indian National Association for Study of Liver for 3 years from 2016 to 2018, and now he is the president of the society. He was the first, when the journal started for INASL again in 2011, he was the first editor-in-chief of the Journal of Clinical and Experimental Hepatology for almost 10 years, from 2011 to 2020. He was governor of American College of Gastroenterology, ACG, for 6 years, from 2011 to 2007. So with these words, may I now request you, sir, to please come and deliver your presidential oration for 2025. Thank you.
Thank you, Dr. Duseja, for your kind introduction. First of all, this is the acknowledgements for the person who have worked along with me. It is a huge team, and the work that we have done in the Punjab and subsequently at the center also. These are the contents of my talk also. I'll start with need for the viral elimination, Punjab model, National Viral Hepatitis Control Program, progress so far and conquering Mount improbable. What are the solutions also? So you all know the WHO target as far as the elimination of the hepatitis is concerned, and the baseline is 2015, and the new infections should be reduced by 90%, and so is the death rate by 65%, and 80% of those eligible should be treated also. So as far as the world prevalence is concerned is around 1%, and 71 million people they are infected, and in India 5.5 million, though the prevalence is very low, point 0 to point 0.6, but because of the huge population, so this is the burden that we have. So things have started from the Punjab, commonly known as the Punjab model also, with a 3.6% prevalence, which is 6 to 7 times higher than the India average prevalence also. And if you look at it, there are 7.5 lakh people who are viremic because of the Hep C also. And this was the infrastructure, district hospitals, subdivisional hospitals, CSCs, and government medical colleges. And the model that we adopted was the decentralized care. That you know that we used to treat at the PGI around 1400 and 1500 patients per year. But we trained the peripheral doctors posted at the district hospital. They are around 120. First, we took a workshop for about 4 hours, but thereafter, we adopted the ECHO program, and every week we will be talking to them. We are discussing the patients also, and we were giving the didactic lectures also, and we were talking to them on a hub and spoke model. Hub was the PGI, and the spoke was the 22 district hospitals and the 3 medical colleges also. And capacity building continued at that time. We involved district epidemiologists, pharmacists, data management operators, and monitoring and evaluation was the most important part that was looked after by the CHAI. So we started in 2000 with 25 centers, and they started increasing 2019 onwards, first 34 and ultimately 67, involving sub-district hospital, ART center, and the OST centers also. So what we achieved in 2 years, because 2018 it becomes the National Viral Hepatitis Control Program, we published our first results based upon the treatment. We treated non-serotic with the SOF and the DACLA, but the serotic it was the genotype based at that time. 2016 was the year also when the SOF was introduced also, and you can see the epidemiology of the according to this study, Sangrur, Bhatinda, Moga, Faridkot, all these districts they have prevalence, viremic prevalence more than 3000 also, and these are the results per protocol. We including more than 50,000. Ultimately, we studied 48,000 after the exclusion, and you can see those who have completed the treatment, SVR rate was around 92%. Those there were the treatment interruptions and completed at least 1 month of the treatment, the SVR rate was 84.5% also. And we can say decentralized care that we started in the Punjab for the Hep C with generic DAs is safe, effective, regardless of the genotype and the presence of the cirrhosis also. Similar results we obtained in children also between the age group of the 12 and the 18 years also. Almost 100% result we got it over here, and we can say decentralized algorithm based public health program can ensure high efficacy cure rates up to the 100% and low cost generic DS based treatment of children with chronic hep C. Then we analyzed, we treated the persons so who inject drugs. We included more than 3.5 thousand patients. Ultimately, 2,280 they completed the course also, and the SVR rate is again 91%. However, the treatment interruptions were comparatively higher when we compare to the normal population, and the results was not bad, 78% also. Again, we concluded decentralized care in SCV with integration into the primary health system established that the treatment PWID with SCV with generic DAs is safe and effective. And this is the paper we have looked for the recompensation in the decompensated liver disease, where they achieved the SVR. And yesterday, Dr. Madhumita Prem Kumar also received the award for this public health paper also. And we defined the recompensation as for the Bevinos 7 resolution of the clinical manifestations such as the ascites without the concurrent use of the diuretic, episodes of the HE without the use of the prophylactic medications, and absence of the recurrent varicose bleed for at least a duration of 12 months after SVR with a concomitant improvement in the liver functions. And we included 1152 patients also, and we demonstrated about a quarter there was a recompensation out, and the predictors included low bilirubin, low INR, absence of the large esophageal varices, absence of the gastric varices, and we may conclude also SVR12 in SCV related decompensated cirrhosis led to recompensation in about quarter of the patients over a follow of the 4 years in a public health setting. So this was the Punjab model and the outcome that I have told you also, and it was adopted by the center by our then the health minister Naddaji, and subsequently promoted by the Amitabh Bachchan ji. And when we started adopted, then we made the national guidelines for the diagnosis and management of the viral hepatitis and the diagnosis management of the hepatitis B also. We performed one study because we were using the genotype based drugs. So we thought that the Sofos and the Velpatasvir, that is the pan-genotypic effective drug. So we found that if the budget is an important constraint, Velpatasvir should be given to the SCV infected cirrhotic patient. Otherwise, the universal use of the Velpatasvir for the SCV treatment is recommended. That is important to improve the adherence of the patient. Otherwise, it is very, very difficult also. So ultimately, the algorithm was non-cirrhosis of DECLA and the cirrhotic compensated soft well for 12 weeks, decompensated it's 12 weeks. If it is rebath, then it is 12 weeks also. What is the current status actually? I'll tell you, there are around 1200 treatment sites across 711 districts in the country, and there are 4,900 master trainers trained at the national level also. Screening, you can see the 11 crore 110 millions for the B and 40 millions for the C also. So how much they are treated, I am unable to get the data from the NVSCV office also. But the recent paper, that is the Polaris Observatory collaborations, they have demonstrated that the Egypt, Pakistan, US, and the EU accounted for 67% of the total, that they have treated about 12.7 millions also. And you can see in the green is the India, almost equal to the European countries that they have treated the hep C infection. And the drug sales data, they suggest the HCV treated between 12, 14, 12, 10, that is for the 10 years in India, is around 7 lakh 6,000, and that comes to around the 12.8% of the total patients treated. I think how much we can believe on this data, I think we have to yet to see also. So the question is that are we on the track? It is like a conquering the mount improbable. What are the challenges that we have to look at? The first is the identification of the anti-SCV0 positive population. And once you identify, then you have to look for the viremia. Once you find the viremia, there should be the linkage with the care, and thereafter the tension on the treatment and the treatment completion and the SVR12 testing also. Coming to the SCV screening, what could be the solutions also? This is the famous study that has demonstrated. If you look at the high risk burden, high risk population, the HIV, drugs, hemodialysis, and so on and so forth also, it accounts only for the 12% of the people living with the SCV infection. But the rest of the 88%, that is the population, is the low risk where the SCV infection is prevalent. So what we can do actually, identification, for example, universal SCV screening, I think the most appropriate, but it's expensive and difficult to implement also. We need to some kind of the modeling in that uh, uh, part also. And we can look the risk factors among the low risk population based on the screening, such as the blood transfusion. I'll come to the study also. And the clustering of the infection in the family that we observe, so we can have the family screening, and we can give the status of the notifiable disease to the SCV. The labs which are doing this test and they found they should notify also. And the most important, whether the self testing for the SCV in Indian population is feasible or not. So this is the risk factors that have been looked into the low risk population. This is the article by Dr. Shalimar from the AIMS also. What they have demonstrated, the number one cause for the risk factors, they found the SCV is most prevalent is unsafe, multiple injection or needleistic injury, followed by the obstetric procedure and the body piercing. So these are, if we looked at this kind of the population and go for the SCV, we might find the most of the people with the SCV also. And there are the studies also that we can have the approach at the peripheral level with the questionnaire based screening. So the one study for the self-reported 72 item questionnaire, what they have demonstrated, if people with the two risk factors, they have 10% chance for the SCV infection. Those with the four or more, the 50% of the chance. And there is another study where there are the 27 item questionnaire in primary health setting, and they have the five domains. And based upon this, what they found, the prevalence, what they have seen in their population, that is 8.3% also, which is four times the national prevalence. So this questionnaire bears screening is also feasible, and this is an one option also. Self-testing device, that is in the oral fluid, it is FDA approved, accuracy is 98%, and it takes 20% also. This is one of the study, that is the self-testing strategy to eliminate hepatitis C as per World Health Organization's goal. So this is a modeling study, and they have looked for the four strategy. The first strategy was the universal screening for the all population. What they have demonstrated, if you look for the Aura Quick or the oral fluid based test, they can achieve a goal, that is the diagnosis in 90% and treatment in 81%. So this is the test that if we can, we need actually a further uh, uh, research in this thing, that whether the oral fluid based test is feasible or effective. So we have an experience, Indian experience also in 15, more than 15,000 patients also. and around 98% participants found it the feasible also, but overall acceptability was 71%. And the validation, they have sensitivity 100%, specificity is the 99%. So these are the preliminary results. So once you have the anti-SCV, the how to diagnose the viremia, I think you have to find out the strategy. That is the one strategy. It is again the modeling study also. Current SCV testing is like that: anti-SCV antibody testing. If it is positive, then RNA testing, and thereafter in the third visit you dispense the medicine also. The second strategy could be that the antibody testing is replaced by the SCV rapid test. So it takes out from the laboratory test, and could be in a non-clinical setting that you can use it, and followed by the SCV RNA testing. Again, the three visits are required. There is a reflex testing also. In the first visit, if the anti-SCV is positive, you do the SCV RNA, and in the second visit, you give the SCV anti-SCV treatment also. The last strategy, that is the single visit test and the treat strategy also. But out of these four strategies, this is the reflex RNA testing was found to be the cost effective also. So I'll discuss, we have some experience from the country also, where the decentralized same day test and the treatment of hepatitis C using existing peer support network among men who injects drug also. What they have done, once they found the reactive anti-SCV antibody sample, they tested for the SCV RNA using the near point of the care TrueNet also. What they have demonstrated, the SCV RNA rapid screening result and the SCV RNA testing duration in between is only 38 minutes, and the SCV rapid screening test result and the treatment initiation, it took only 6.5 hours. So that is the thing that is doable also. So community-led hepatitis care incorporating same-day test and the treat for SCV was feasible and the effective also. So that is the one strategy that we can look. The most important thing is that after the you find the viremia, how to adhere to the treatment also. And this is the most I think the most quoted study also, where they have given the 12-week course of sofosbuvir and the velpatasvir at one time, and there was a four component of minimal monitoring included. They are no pre-treatment genotyping, dispensing the entire treatment course at the entry, no schedule on treatment visits or laboratory monitoring, and the most importantly, the remote contact at week 4 to assess the DA's adherence, and the week 22 for the scheduled SVR also. And you see the results that the SVR was 95% also. At the present, what we do, at least 6 and 8 visits are required for treating a patient at the moment. 3 to 4 weeks visits required for the case identification, and 3 to 4 visits they are required for the treatment also. What is proposed that in first visit we should do the antibiotic test, and the same time we should do the SCV RNA using the point of the care test, and dispense the DAs at one go and collect the sample for the LFT or the hemogram. And the in the second visit should be for the SVR testing using the POCT. But most importantly is that there should be a remote contact at week 4 to assess the DA's adherence, and week 22 for the scheduled SVR. And interpretation of the test, non-invasive test for the cirrhosis, if it is there, then advice for the future care also. I think this is the proposed cascade. If we could, that could be done at the moment also. And there is the one study that would help for the adherence also, that is done from our department also. It is a multi-center non-inferiority trial where they have demonstrated that software for 8 weeks is non-inferior to standard 12 weeks treatment in chronic hep C infection without cirrhosis. So, ladies and gentlemen, I like to conclude. India has a huge burden of hepatitis B and C. National Viral Hepatitis Control Program has made an impact. Training of the healthcare workers, there are around 1200 treatment sites across 711 districts across the country, and there are 4,900 master trainers trained at the national level. Drugs are available to all districts also. Substantial number of the treatment centers have been started across the country also. Viral load testing has been established, but what I have told you in near future, what could be the strategy so that we can identify the patient who is having hepatitis C infection, that is more important, but still 2 miles to go, need to review screening strategies and link us to the treatment. Thank you so much.
Thank you very much, sir, for taking us through your journey with hepatitis C elimination. It's customary not to have any questions or comments after the oration, so we'll request you to come at the center for the felicitation ceremony.